you all are out here at 10 a.m. on a Saturday morning. Thank you so much. I'm honored. So I do have a couple of disclosures. I have been a consultant for NeuroNav, for Medtronic, and have some research with them. And then also there's a study that I'm going to be talking about, and I am on the FDA Data Safety and Monitoring panel for that, just so that you are aware. Also, I want to tell you that about 99% of what I'm going to talk about today is FDA off-label. These are experimental targets. We're going to be talking about some of the research, etc. We're going to talk about these targets, so thalamic pain, MIGS, cluster headache, aggressive behavior. These are all experimental targets or approved targets for deep brain stimulation. If you think of DBS in general for essential tremor, Parkinson's, dystonia, and then a humanitarian device exemption for obsessive compulsive disorder. DBS has been around for a really long time, since '97 in the United States, and since 10 to 15 years earlier than that in Europe, because they get things early. There's over 200,000 leads, 100,000 patients. So I'm not talking about a device or a therapy that's experimental, but I am going to talk about what's coming, what we're thinking about. There's some basic techniques. There's a frame, or a couple of different frames. The frame that you see with the arc on it, that's the Lexcel frame. Then there's a next frame, and then there's a frame that's built specifically to that patient's head. All of the goal of deep brain stimulation is to essentially get a wire with some 1.5 millimeter contacts or so deep inside the structures of the brain. There are multiple targets using stereotactic methods, which is essentially Cartesian geometry. There are FDA-approved devices, and there are now 2 of them, which is an update based compared to the last time you heard me talk about deep brain stimulation. Medtronic and St. Jude Abbott are the 2 approved devices. Awake versus asleep is the first thing you're going to hear about. And that's a big conversation in our community, because there are folks who do asleep DBS and there are folks that do awake DBS. One day I'm going to bring my friend up here and we're going to have a battle like Dr. Nelson and Dr. Bauer are going to have over awake versus asleep. But what's the difference? So when we do awake deep brain stimulation, what we are doing, it's 90% asleep, they're snoring, and about 10% awake. But the awake part is very important, and I will admit that I have a bias to awake deep brain stimulation, and the reason for that is we listen to single cells in the brain all the way down to our target. Different parts of the brain have different frequencies and different sounds, and awake deep brain stimulation allows us to know that we are in the exact right spot. We then place our lead, we turn it on, and we test it. So we watch symptoms improve, we watch things get better. If you're doing a sleep deep brain stimulation, then the patient is completely asleep, and there is no feedback, so you can't test your device, and you also have a lot of difficulty. Most times you cannot hear the cells fire, so you're not sure where you are in the brain. You're pretty sure you're in the right space, and you verify it with an image, but all that image does is show the tip of the electrode to the tip of where you plan things. Well, that might be the right place in a patient's brain, but about 30% of the time that's not the right place, and you have to do another track. If you can't test where you are, then you might leave something in the brain that is just out in space doing nothing. And so, in my opinion, if a patient can tolerate awake surgery, and 99% of all patients can, it is a far more accurate, much better option. So that's my bias. But this is a study, Dr. Burchell, Kim Burchell out of Oregon, using CT, a device called Serotome, using CT with a 3T merge. He did 60 patients, 119 electrodes, and he used essentially all 3 targets that we go to in the brain for movement disorder, VIM, GPI, and STN. And he showed that there was no difference, and only 1 was repositioned, secondary to error, and concluded that it was, quote, at least as accurate. All right, well, I told you my bias. In my book, when I'm putting something into someone's brain, at least as accurate isn't good enough for me. Absolutely accurate is what we should go for. But I have to show you the study. Something else that's coming, this is FDA off-label, is closed-looped. So currently what we do is we put an electrode in the brain, we connect it to a wire under the skin, and we put it in a battery in the chest wall. And all we do is send electricity to the brain. Certain frequencies, certain pulse widths. We send a feed-forward loop only. We now have FDA experimental devices that are closed loop, meaning that electrode can then sense waves or electrical activity in the brain, send it back through the electrode and to the device can record it, and the idea is that perhaps what we can do is actually change the stimulation based upon abnormal electrical activity going on in the brain, so that we're not always just applying electricity, we're doing a very specific form of electricity to that patient's brain. And it's based upon computational modeling. This is primarily being done in Parkinson's. There's a band of electrical activity in the subthalamic nucleus called the beta band. And in folks with Parkinson's, that beta band becomes out of whack, we're going to say. And so what the idea with closed loop is, well, what if we provide stimulation only when the beta band is abnormal, and when it normalizes, we shut the stimulation off, we let it go until it's abnormal again, and then we turn the stimulation back on, and we don't have to do that. The device would do it itself and do the analysis itself. Preliminary data is starting to show that that's actually effective. What we would worry about is, well, gosh, if you let it get abnormal again, are they going to fluctuate with their Parkinson's symptoms? We don't seem to find that that's the case. So this is exciting for two reasons. One, we can personalize stimulation much more, but two, we can learn what's going on in the brain. So we're actually learning from these folks. I have a good friend who's implanted with one of those devices, and it's been really interesting to watch his experience with that. So closed loop is coming, and it's exciting. Right now it's for Parkinson's, but why not for some of these other targets? This is FDA approved, and what we're moving towards now are directional leads. So I put several options up there of what directional leads are. So essentially, if you think of a lead, it's a wire with a circular metal contact. You provide electricity in a circle surrounding that, and it creates a sort of a ball of electricity activating the tissue surrounding it. Sometimes with deep brain stimulation, if those leads are sort of okay, almost as accurately placed, it can stimulate structures that are very close. For the STN, you're looking at a 7 millimeter by 7 millimeter target deep in the brain, and it's surrounded by the internal capsule and the medial lemniscus and the lambic structures, etc. And so if you get too much lateral spread, patients will curl up and get dystonias and have uncomfortable spasming. So what if you could just drive stimulation more medial then and stay away from the lateral side? That's the idea of directional stimulation. What we're learning, though, is it's actually a little bit more complex than that and a little more interesting than that. It's not just about driving stimulation away from an area. It's about increasing tissue volume activation of the tissue itself and using lower energy. So there is a directional lead on the market, and that directional lead has two circular, one at the bottom, one at the top, and the two middle sets of contacts have three separate contacts. So you can turn on just the anterior, just the medial, just the lateral, and stimulate about a third. And so what we see actually is that you get, and this is a very busy slide, but what we can see is that you get higher tissue volume activation with a smaller electrode and lower energy. That seems contradictory to what we would think about in electrical applications. So as these patients are being implanted, what we're learning is it's not a takeaway kind of thing. It's not like you just do what you've always done, and then when they get a side effect, you subtract one of those contacts. What we're finding is, in fact, what you do is you map out where those triumvirate contacts are, and you only turn one on to start with. So you use less energy, you preserve battery, you activate more tissue volume, and you get effect And then you have a lot more opportunity as you move forward. And this paper out of Germany does show that, as does this one, which is the first report of the clinical outcomes for Parkinson's disease. And it shows that it is effective and that this directional leads, all the companies are coming out with them, just so you know, but this is very interesting, it's very new, we're learning. And the other thing it is it's teaching us, again, how the brain works. So the beauty of deep brain stimulation is not only are we able to affect change in somebody's life, but we are also able to learn more about the brain in a way that we've never been able to learn about the brain before. And so this shows that directional, this is a slide that shows the directionality, and you can see those activations. What are the current frontiers? Well, these are all the different things that we're looking at for deep brain stimulation right now. There's a lot of them, we're not going to cover all of them, but I wanted you to know that there's a ton going on in deep brain stimulation. Why does it excite me? Because, you know, we're doing stuff with tumors and we fuse spines and all that kind of stuff that my partners are going to talk about, but we're learning and we have so much room and space to grow. These are the different targets in the brain. A lot of what we're going to talk about is nucleus accumbens, which is right here, VC, which is right here, and then the typicals, GPI, VIM, and STN for targets. But nucleus accumbens and VC, VS, those are really anterior cingulate, those are really interesting targets in the brain. So let's talk about anorexia. So one of the targets that we're looking at is our anorexia nervosa. We've got 4 targets in the brain, as you can see. SG25, nucleus accumbens, hypothalamus, and VTA. Well, why hypothalamus? Hypothalamus is where you control your satiety or your hunger. Why nucleus accumbens, and why we're going to talk a lot about this target in the brain? It's the reward center of the brain. It's the part of your brain that responds to the dopamine and the serotonin when you have an exciting event, when you have a pleasurable experience, when you use drugs or alcohol, which we'll get to. And so that's a really interesting target in the brain. And so what they initially looked at is they placed a laser to a battery in mouse models of anorexia, and they found actually that they could stimulate these mice to eat and increase their intake. And so this is an actual human trial, and what you can see is that the BMI of each of these patients increased significantly. It increased significantly to start, then you get a drop off, and you sort of do get that as the brain habituates a little bit. But then you start looking at the BMI. We have folks who are actually up to normal BMIs, 20, 21 BMIs in these patients. Now, it's a 6-patient trial. However, this is a small group of people. These are people who are totally refractory to all other treatment, to therapies, and who actually consented to surgery. And so this is really exciting. This is actually, the target is the subcallosal cingulate gyrus, which is part of that loop of Papes, which is part of that reward center, satiety, hunger. And so what we know now is that we can do deep brain stimulation for anorexia nervosa. And as you look at the changes, it's sustained over 9 months. Look at some of these BMIs, 11.1. That patient, that number 1 patient, BMI at the end, 9 months later, 21. These are people who are ready to die of their anorexia, who are literally BMIs of 11. I don't think I've ever met a human who's alive with a BMI of 11, right? So this can make a huge, huge difference. And so, but I've got an ethical question for you. A lot of these folks are under 18. Anorexia nervosa occurs in a younger population. There's bimodal peaks. Young, under the age of 18, and 35 to 60, but typically those are refractory and they had a previous eating disorder, but these are these refractory patients. So that's thing 1. And thing 2, folks with anorexia typically lack insight. If they didn't lack insight, if they didn't have body dysmorphic disorder amongst their other disorders, they'd be eating. But they look in the mirror and they say, oh, there's nothing wrong with me. Actually, what's wrong with me is I weigh too much. And they restrict. And so if you take people who have no insight into their disorder and who aren't able to legally consent for themselves, what are the ethics of placing wires in their brains randomly to try to fix this problem? And should we be able to compel them to participate as part of their treatment. What are the limits of coercion in these patients? Well, if you let us do this, if we place this device, you get whatever reward, because that's how treatment for anorexia nervosa typically works, is a reward, like an operant conditioning type system. So I don't need you to answer that. This isn't one of those APS question things. I just want you to start thinking, because I'm a bioethicist and that's what I like to do, thinking about what does it mean to put deep brain stimulators or to do experimental brain surgery on young people with no insight with psychiatric disorders. Kind of interesting, but can save their lives. Let's talk about thalamic pain syndrome. I will, in full disclosure, tell you that I implanted the first 5 of these 10, and my mentor, this is his trial. This was a DBS trial, so thalamic pain syndrome is a post-stroke syndrome. It is one of the worst pain syndromes that we possibly have. It's almost impossible to treat. Typically, post-stroke, about a month after stroke, people will get a hemi-anesthesia, so that half of their body will be insensitive to touch, but if you touch them, they don't feel the touch. It's called anesthesia dolorosa, but touching them causes horrific pain. So taking a shower, the wind blowing, their clothes on their body, it's horrible, debilitating. Neurontin doesn't work, narcotic pain medications don't work. These people are miserable. So in thalamic pain syndrome, it's a somatosensory thalamic nucleus problem, and it's unrelenting, and it's disabling. And so there's this neuromatrix theory proposed by Melzack that pain is processed by an integrated network of somatosensory, limbic, and cognitive pathways. And here's what's important, limbic and cognitive pathways. We can't change the somatosensory. There's a stroke there, right? That's damaged, and I can't alter that. But what if I can alter the pain in the limbic system or in the cognitive system? So targeting only the sensory pathways aren't a viable option. So what we did is we targeted structures that process emotion and affective behavior, particularly the ventral striatum and the anterior limb of the internal capsule, VCVS, that VCVS target. It was a 10-patient, it was double-blind, randomized. They all got implanted, and then they all had a 6-month on versus off that was double-blinded, both to researcher and to the patient. And what we were looking at in these patients was their suffering. And that's really important. It's hard to wrap our brains around it, but they're suffering. So what you would do is say, well, what is your pain? My pain's an 8 out of 10. What's your anxiety? It's a 2. What's your suffering? Nothing. With the device on, and then with the device off, what's your pain? Oh, it's an 8 out of 10. What's your anxiety? I'm a 9, and I am suffering. Like, fix this. Kind of a thing. That's the idea, and that's what we were looking at. So our primary endpoints were pain disability, a VAS, and some quality of life measures. The interesting thing about this is that it's only 10 patients, right? The interesting thing about it was not only was it affecting the affective component of pain, which we don't think about a lot, but is very important, but what is it doing in the brain? And we can actually see that we can change areas of the brain. We can activate, this is FDG PET, for a patient in the off state and the on state. So you can see that there's hyperactivated areas of the brain, multiple areas, bilateral thalami, bilateral, parietal temporal, high anterior cortical. And then you turn this on, and all of a sudden, and in particular, the thalamus shuts off, right? And a lot of this anterior frontal stuff shuts off. So we now know, so one of the things it proved is A, it was safe, B, that it may be effective, we need a larger N, but C, we are actually changing areas of the brain from an electrical perspective far distant from where the wires are. The wire is right there. And look, we're changing all of this. So it's really important, and it's what we've learned, and it's a way to affect. So it is safe to surgically intervene. It's possible to successfully complete a randomized controlled trial with folks with chronic pain, because you can imagine there can be some difficulties there. There were improvements in pain levels, and their depression was better. And it's possible to safely conduct fMRI studies in patients with DBS, which is very important. Let's talk about Alzheimer's. We got a big problem with Alzheimer's or cognitive issues. And so there are several studies that are looking at deep brain stimulation in Alzheimer's. This one is a 2012 study, 5 patients. We have to say mild probable Alzheimer's disease because, of course, you cannot diagnose Alzheimer's disease without a brain biopsy post-mortem. There are some studies like EPO-E. Folks who are EPO-E positive have a much higher likelihood. So if they have cognitive deficit and they're EPO-E positive, they're more likely to have Alzheimer's. So what this study showed was there was increased glucose metabolism in these frontotemporal, parietal, striatal thalamic networks. And this is the network for memory. And it's the principle of the hippocampus. So there are a couple of places that you could stimulate in this network to change. You can stimulate the fornix, which we'll talk about. You can stimulate the hypothalamus, but that tends to bleed a lot. You can stimulate entorhinal, and those are the 2 places, entorhinal and fornix, that we're looking at. This is another model of that, where we can actually stimulate the anterior commissure, the anterior thalamus, or the mammillary bodies as other options. So this is the study that I sit on the Data Safety Monitoring Board for, which is the ADVANCE trial. This was bilateral fornicele stimulation. The interesting thing about this trial, so this was 45 patients. It's going on to a stage 2 that's in the works. The interesting thing about this is that the fornix is not something we would think about to stimulate, because to get there you've got to go transventricular. Well, what do we worry about? We worry about bleeding in the brain of folks, and where are there a lot of blood vessels? On the lining of the ventricles. We also worry that to go through the ventricles, we can cause cognitive decline. So now is the emphasis. We're talking about going straight through the ventricles, high risk of hemorrhage, high risk of what we think is high risk of cognitive decline in people who are already cognitively susceptible. What we found, however, was that there was actually no increased risk of hemorrhage, no increased risk of cognitive decline in these bilateral, done at the same time, transventricular fornicele stimulation techniques in patients with Alzheimer's. I hope what you're learning from this is not only are we learning about our target and what we propose is going to get better, but we're also learning about how the brain works. We're learning a little bit about neurosurgery that we didn't know about before. And so these studies are really important, not just for the disease state that they're meant to affect, but for what we're learning and how we can change other disease states. The other area was entorhinal implantation, which is mesial temporal. This one came about because these were folks who had mesial temporal epilepsy. They put wires in because they were doing some studies to decide whether or not they were going to have resection for their epilepsy. And, well, the wires are in there. Maybe they can give us some information. Maybe we can give a little stimulation and learn a little something about learning, because the hippocampus is where we think memory sits a lot of the time. So what they did is they applied stimulation in these folks who had these wires in place for other reasons, and they found that on a video game driving learning task, they improved their learning with stimulation. So they were able to take folks with epilepsy who sort of have a cognitive deficit anyway, and they were able to have them learn faster and better. So, okay, now let's extrapolate that to folks with Alzheimer's disease. We're just changing electrical circuits, right? So they did implant folks, and they were able to, again, prove that you could affect cognition. Here comes that pesky ethicist again. So based on that previous slide where you can take essentially normal subjects, and you can put wires into their brain, and you can make them learn better, what about the enhancement of non-demented subjects? What about folks who just want to do better? What about people who are competitive and want to go to Harvard, like my buddy over here, and say, well, put this wire in my brain? Or what about, this might scare you, but they are looking at this, I didn't put this in, but they're looking at this, what about the military? What about we want them to move faster, move better, be smarter, think harder? You're my soldier. You're going to let me put this in your brain so I can control it, so you perform better at your job, and you pretty much have no choice. What about that? So does the consenting adult have the right to surgical enhancement of the brain just because? And what about evening the playing field? Not everybody could have this surgery, right? So then it biases to the rich as opposed to the poor. We talk about all kinds of economic things. So I'm just planting some seeds. Let's look at epilepsy. Dr. Lozano, who was also on our advanced trial and is one of the premier deep brain stimulation functional neurosurgeons in the world, out of Toronto. And epilepsy is an approved indication in Canada, by the way, just not the US. This is prelim data on patients with implanted DBS for control of intractable epilepsy. And what we're able to see is that we are able to get it's hard to read, but an 83% reduction in seizure, a 30% reduction in mean seizure reduction at several different targets. And each of these patients got anywhere between 30 to 83% reduction in their seizure activity. Seizures can cause death, they can cause cognitive deficit, they can cause significant quality of life issues. So these devices are safe and they do decrease. I'm going to talk about something that's not deep brain stimulation. Talk about a device called NeuroPace, which is FDA approved for epilepsy. This is a device in which we place typical regular electrode, either deep depth electrodes or cortical electrodes in the brain in multiple areas. We connect them to a battery that's implanted in the skull. And what it can do is it can detect, so there's this cortically implanted lead here, and here can detect kindling of seizures. Once it detects kindling, it can then apply an electrical field and arrest seizures. And it is effective, and it can be implanted to this day. So I'm going to fly past MIG syndrome because there's some more interesting stuff, but it's blepharospasm, cervical dystonia, facial and oromandibular dystonia, and you can do thalamic or basal ganglia lesions, and there's some studies. Cluster headache. Let's talk about cluster headache because it's debilitating. Well, these are PET flow activation in the posterior hypothalamus, and so in Italy, Dr. Franzini has done 50 posterior hypothalamic patients. The interesting thing is you can functionally modulate the brain. So we're not just inhibiting or turning off structures. What we learned from this is that we're functionally modulating the brain, as you can see. The problem with posterior hypothalamus is it tends to bleed a lot. So you had a high complication rate from a bleed perspective. It's not something that we're doing here in the US, and it is problematic, but I want to mention it because it's out there. Tourette's. Tourette's is a huge one. And there are several targets. Centromedian, ventral oralis, internuclei of the thalamus. We like big names in anatomy. They get moderate results. What gets great results is nucleus accumbens, that reward center, and GPI. That's a target for movement disorder. Why does GPI work? Because we think that part of Tourette's is actually, the tic part is the motor part, and so GPI may control the tic piece of it, and nucleus accumbens may control the oral piece of Gilles de Tourette's. And so randomized crossover with GPI and bilateral thalamus got better symptom control. What did we learn from this? Well, not only can we change Tourette's syndrome, but sometimes putting leads in two places to treat two different pieces of a disease will be more effective than not. Again, we're learning about how the brain works while we're trying to treat a disease. Aggressive behavior, Franzini again, those Italians, they're doing crazy stuff. But anyhow, these were 6 patients with very aggressive self-mutilating behavior. Posterior medial hypothalamus, he really likes that target for whatever reason. And they had significant improvement. And there's a case study. So we're looking at 7 patients worldwide. But if you have somebody who's chewing their fingers off and hurting themselves, or are aggressive, pathologically aggressive, implanting may change their life, may make them functional and able to have a life. Here's that pesky ethics question again. Is it ethical to subject patients without capacity to surgical risk? Folks chewing their fingers off can't decide whether or not the risks of a surgery to the posterior hypothalamus. Remember I said that one bled a lot? So what are the ethics of that? And then what if we can modify aggressive behavior? What are the implications for criminal behavior? Like, do you get to eventually someday, are we moving towards a world in which we could implant devices into criminals to keep them from doing things we don't want them to do, to mind control. It sounds crazy, but the reality is there are folks out there thinking about it, working on it, and we need to be aware of it. Here's another interesting one. Because in the United States, Colorado was, I think, the last state to go over 20% obesity. But even here in our beautiful state, we have greater than 20% obesity. There are several animal models of obesity and also of alcohol addiction. But these are huge medical problems. That reward center, that nucleus accumbens, that reward center of the brain is what we're targeting for both of these. This is a very busy slide, but it essentially just shows the pathways. Why do I put up a lot of these pathways that are really hard to follow? Because what I'm pointing out is you can hit things from different areas. Well, what if you hit it here and you hit it here? Or what if you try here and it doesn't work, but you try here and it does? So we have a lot of work to do, but there are reasons. We're not just randomly choosing places in the brain, but where we choose for this is nucleus accumbens. And so what we've learned is that you can minimize satiety. There is a study, and I didn't put the slide in because I was trying to sort of condense. There's some study with heroin addiction out of Amsterdam. They're able to take about 10 patients and decrease their relapse off of methadone, off of heroin, and no relapse. So that's the addiction piece of it. And then the obesity piece of it was really interesting because it's nucleus accumbens, but they're also looking at that, remember that fornix back for Alzheimer's, Dr. Lozano? That's how he figured out that he might go there for Alzheimer's. He was implanting fornix as part of that satiety stream, and what he found was when he turned the stimulation up really high to try to prevent a morbidly obese patient from having desire to eat, the guy was always hungry, could not stop, he could also elicit memory, vivid memories. And he went, what if we stimulate here to treat cognitive deficits? So the other reason I bring these things up is to point out that we might start in one place for one disease, and it might take us somewhere else for another disease. Because again, why am I excited about deep brain stimulation? Because we are learning about the brain. OCD is an FDA approved, and so I'm just going to slide past that. We have we've implanted a couple of OCD patients here in Arizona. We've done it a lot in Arizona. That's where a lot of the studies were done, but here in Colorado. This is the Ocd Studies Depression. A lot of people ask about depression. There were 2 trials in depression, 2 major trials. Both of them failed. I'm going to tell you why. They were poorly designed. They were mostly run by the companies, which was a problem instead of the scientists. But as we sat around and we had failure of these trials because our early trials showed that subcingulate gyrus is one of the targets, and we see that 21 patients, bilateral subcingulate gyrus, they got significant reduction in their depression scales, reduction in depression symptomatology. They had a change in their depression scale from baseline. All of the subjects had a change at up to 12 months post-implant. And the percentage of responders was much higher than the percentage of remitters. So, and we can show that we can change glucose metabolism. This is important in areas distant to where we are stimulating, right? So what happens? Why did our big trial fail? I'll tell you why. There's 2 types of depression, two basic phenotypes in depression. One is very withdrawn and quiet. The other one is really like hyper dramatic. We had 2 targets. We had VCBS and we had subcingulate gyrus. When we started talking, going to our meetings and talking, folks in Emory said, well, gosh, our folks that responded were the folks who were very withdrawn, very quiet. And our folks who didn't respond were those. And then the other target was primarily the Cleveland Clinic. Our folks were the hyper and not the withdrawn. What if it was designed the wrong way? What if it was the wrong phenotype for the wrong target, and now we've learned that we need to redesign it for that? So I want to tell you one more thing, because this was just sent to me last night. It's not in there. What was sent to me was non-invasive DBS. So some folks at MIT have created, the idea is that you can stimulate when you apply electricity, you're changing across an electrical membrane. You're changing polarity. So if you stimulate at approximately 1,000 hertz, you don't actually get electrical changes in the circuitry. But if you stimulate on one side at 1,000 hertz, on another side of the brain, opposite at 1,000 hertz, those fields will pass through normal brain, arrive in an envelope, your target, and activate at the appropriate, they potentiate each other and activate at the appropriate level, and you can create activation deep in the brain of mice, which are smaller than humans, although some people's brains are the size of mice. No. You can do this. So there is some talk about what about non-invasive deep brain stimulation. What I want to point out to you is there's a lot going on. It's not just about one target. It's not just about one therapy. It's about learning how the brain works. It's about changing people's lives. There is so much to learn. So to quote a nice 80s band, the future's so bright, I gotta wear shades. Thank you so much.